Hello docs. So this is a video tutorial on our current process on how to work up or gather data, diagnostic data for TMD patients. Much of this is, in my experience, outside the usual skill sets of most general dentists. With that said, I have found that this sheet, which is an aggregate of many different sources, to be a very nice way to examine a patient with a system in place, so that you don't have to think about all of the different things to gather. A lot of this is very thorough, but when you start providing diagnoses, you'll start to see that the thoroughness is what gets you the proper diagnosis. We all have made the mistake. I've seen it. I still do it too today, where we look at a patient, we take their signs and symptoms, and then we try to provide a diagnosis based on our experiences. That's not a diagnostic process. That is throwing a dart at a dartboard with whatever dart you just found on the floor. That's not going to get you to where you need to be. So I'm going to go through this. I can appreciate that some of this is going to require some additional training. With that said, I think 80 to 90% of this anybody can do based on just basic general dentist training in school. All right, so let's start. I will do my best to explain things with some other video or some other tools. Let's start with patient's chief complaint. Obviously, that's a very important thing to have. You want to try to use their words. There's a lot that comes out to being very succinct in the wording that they use. So patient chief complaint in the top there. If there's multiple chief complaints, go ahead and put that. Signs and symptoms, most of this is pretty self-explanatory. I can appreciate that some of this looks obvious, but as you start to provide diagnoses, you may come back to a very specific aspect to this. These are 10,000 foot view comments that often provide insight. Okay. Sleep compromise is part of the TMD workup, as we will find out very soon with Dr. Walker's lecture. Past history of head and neck trauma, related or unrelated to the chief complaint. Common example is patient was in a car accident at a young age, and they now have clicking and popping in their left joint. To the patient and to the untrained observer, those two may seem unrelated, but as most of you guys can surmise, that they often are related. Past relevant medical history. Obviously, the medications, SSRIs, can cause some issues with bruxism, so on and so forth. So anything that you think might be connected, put here. Sleep pattern, onset, hours of sleep per night, awakenings per night due to chief complaint, difficulty returning back to sleep. You know, all of this is pretty self-explanatory. If you have any questions, feel free to reach out to me. Significant components of chief complaints. So here you're getting a little bit more descriptive on what's going on. You're using your experience in the context of their chief complaints to write down some ideas for you to look at in the future. These are notes for yourself to put together the diagnosis later. Do not feel like you need to get a diagnosis during the data acquisition. Very common mistake. This is complex. It's going to take some time. It's going to take some research. You're going to break out a textbook, and you're going to figure this out after. Okay? There may be times when it's obvious, but I really encourage everybody not to feel the need to try to put the pieces of the puzzle together until you've done this 1,000 times. And even then, you probably won't want to provide a diagnosis until you have all of your resources available to you afterwards. So history of chief complaint, onset, describe historical aspects involved with the original onset. So really, you're just gathering data on, how did this start, what kind of contributing factors led to it, so on and so forth. Trauma, describe trauma if related to the chief complaint, if there was an incident of sorts. Quality, what does the pain feel like? obviously, sharp and dull are very different diagnostic tools that we use with odontogenic pain. So you want to make sure that you use that same kind of analysis here. Quantity, temporal pattern. So what's the timing of it? Is it worse in the morning, worse at night? Does it wake them up at night? Timing is very important for providing a diagnosis and the proper treatment. Duration of pain episodes, verbal analog scales, essentially what is it today, what's the average day to day, what is it when it's the worst, and what is it when it's the least. And then some sort of description on what contributes to those coming and going, change or progression over time. Initiating factors, what are the things that really trigger it? So stress is a common one. When I'm stressed at work, it tends to get worse. That would be an initiating factor. Aggravating factors, when it's present, what are the things that make it worse? Likewise, alleviating factors, what are the things when it's present makes it better? Associated symptoms, so when it arises, so I have TMD, I then have back pain at the same time, or I get dry mouth, my teeth get sensitive, so on and so forth. And the patients may not have answers to these. Just put NA, not applicable. Current medications and supplements, I guess at the top there with relevant medical history, omit medications for that part and put them here. Postural evaluation, we will be getting a doctor of physical therapy to come in and help us get much better at what all of this means. Head position, what's normal, what's abnormal. We're looking for very gross abnormalities. Much of these we can see on the photos that Chantel takes, and many of us have done that analysis together to try to get a sense of whether or not their nathologic system is out of whack before we start to do a full mouth rehab on them. So essentially, is the head tilted left or right or forward? Describe it here. And then shoulder position, are the shoulders uneven? History of orthodontics. Teeth that are straight often infringe upon the nathologic system. That is, in my estimation, a big part of our future world. Not to say orthodontics are bad, but orthodontics done without appreciation of the nathologic system can be detrimental to patients. And it's often the cause of their TMD, but it occurs much later down the road, so it's very hard to provide or identify a causal relationship between the two. Again, we're going to dive into this a lot more over time, but it's good to have a history of when the ortho was, who was the orthodontist, what was the length of treatment, so on and so forth. And if we can get any records from the orthodontist, that's often very helpful. All right, so here we start to get into the clinical examination. So everything up to this point are questions for the patient. As time goes on, we'll definitely encourage the support staff to do much of this for us. With that said, I want everybody to be experts before we start delegating. So let's all get good at it together. So as far as the examination goes, before I start, Spear talks a lot about the simple fact of making sure that if you put a glove in somebody's mouth, make sure you didn't just touch the outside of their mouth. Although I've never heard of this happening, in theory you could introduce a staph infection. Staph lives on the skin for the most part, and then you introduce it to the inside of the mouth. So, and then the flip side of it is if you go in the mouth and then go to the outside, you have their saliva on them. That can be disgusting to a patient to feel their saliva on their skin. So I'd encourage everybody to be cognizant of this as you do your exam. Do the inside of the mouth separate from the outside of the mouth. I wouldn't necessarily say one is better than the other, as long as you switch your gloves or dry your hands. I would just switch the gloves. So as far as the specific items here, so lateral pull, let's go to the TMJ image. Of course, it won't let me do that. There we go. All right, so the lateral pull is essentially that point right there. You tend to feel this when you're palpating just in front of the ear. I will say that this model here, the ear is much farther posterior than it actually is. The ear canal obviously is right here. So this ear is positioned posteriorly, but essentially you palpate the TMJ right in front of the tragus of the ear. So it's like right there in relation to the extra facial landmark of the ear. If you don't necessarily know where it is, have the patient open, and then you'll feel this fossa created. Essentially, where you feel the fossa is where the lateral pole of the condyle is when they close. So have them open, you'll feel that depression open up, and then have them close, and what you'll feel is the condyle, what you're feeling is a lateral pole, slide into that space when they close. That's the lateral pole. So that's what you're feeling for. There's a specific condition called capsulitis that we're assessing for, amongst a few other things. So that first one is very easy. Let's go back over here. So yes, you're going to feel the left and the right, 3 being the most painful. The posterior lateral aspect. What we're feeling for there is that depression. So you have the patient open wide, and you're pushing with your pinky, because our pinkies tend to get deeper in there than any of our other fingers. You're feeling for the lateral aspect of the condyle. You're not going to get to the medial aspect. So the reason why we don't see anterior or medial aspect of the joint is because we can't palpate that. What we're palpating is the back side, the posterior compartment space where the retrodiscal tissue is, and the lateral pole. That's all we're able to do. More often than not, if there's inflammation in the joint that's severe enough to cause a problem that we need to treat, you're going to sense that there. You can also, with the patient closed, put your pinky in the ear canal and actually push forward. There is a bony housing there, but many times the soft tissue that's associated with it is so inflamed that pressure inside the ear does hurt. I don't necessarily find that, but Spear talks a lot about that. I find more positive signs, meaning discomfort on palpation, when I have the patient open and I put my pinky in the retrodiscal area. And then vertical loading is essentially, with the teeth closed, applying an upward force of the entire mandible, focusing on loading this superiorly. I'm not sure exactly how helpful that is. That might be my naivety in the situation, but I get most of my information on the next one, which is clenching on a separator. What clenching on a separator does, it allows all of the force from the masseter, which sits right over the angle of the mandible, and the temporalis, which obviously lives up here and inserts on the inner aspect of the mandible. They're both elevator muscles with a some vector of force in a kind of a 1 o'clock direction. Clenching on a separator allows those muscles to exert a vector of force straight in this direction. And what that does, it gives us a sense of whether or not the condyle is sitting on the disc or if it's sitting on inflamed tissue. If they clench and it hurts, that gives us a lot of data. As you can see, what we're looking for is clenching in the anterior, so you're clenching between 8 and 9, and you're getting a sense of where pain might be. It might be in both joints, it might be in one joint. Then you're going to put it posteriorly on the right, and then you're going to have them clench. And most of the time you're going to have contralateral pain, because the condyle of the contralateral side of where the clencher is unfortunately unprotected. So you get a lot more force in the condyle on that side. And then you correspond the amount of pain that's there. So clenching on a separator is very helpful for determining whether there's inflammation in the joint, but you may also get masseter pain and sometimes medial pterygoid pain when you do this. So you have to be specific on where the pain is. Is it a sharp sensation in the joint, or is it a general pain over their muscles? And this brings me to another point. When patients describe pain of TMD, if it's inside the joint, they tend to use a finger. And if it's a muscle thing, they either say, I don't know, it's on that side, and they just don't even point at all, or they use the palm of their hand or several fingers. It's a much less localized kind of pain. Again, we'll get to different diagnoses, but myofascial pain disorder tends to be a very ambiguous set of signs and symptoms, whereas pain within the joint tends to be a very localized, non-referred pain. I say non-referred, it definitely can refer, but you don't see trigger points per se, which are referral pain patterns. You tend not to see trigger points per se in the inside the joint if there's inflammation there. And of course, there's patients who have both. So it gets complex, but it's good to know how patients describe their pain and what that tells us. All right, so that's it for clenching on a separator. You can use a cotton roll. You can use a variety of things. There might be more value into using something stiff rather than a cotton roll, because a cotton roll has a varying degree of pressure, which might do something funny with the muscles. So use something along the lines of a tongue depressor or cotton tip applicator. Just use like the wooden stick and have them bite down. As long as it's stable and their muscles aren't moving around trying to stabilize whatever you're putting in there, it will work fine. Which just answered my question of why you shouldn't use a cotton roll. So use something stable. TMJ auscultation. So this is essentially listening to the sounds within the joint. There are all kinds of opinions, methods, techniques on this. Historically, a stethoscope is used. You can really hear whether there's things going on inside the joint. We're looking for sounds. What do sounds do? They indicate pathology in the joint. There's actually quite a bit of data that indicates sound is even better than radiographic determination when assessing for active pathology of a joint. Inside of a pathologic joint, you have crepitus, you have surfaces that are not very good against each other, providing almost like a sandpaper on sandpaper sound, or even two pieces of rubber against each other. There's all kinds of sounds that come out of this to indicate what kind of pathology might be in the joint. I'm not there yet, and we're not there yet, but there are tools such as Doppler. There are JVA, joint vibration analyses, which are tools that are helpful in assessing whether or not there's very fine, non-audible vibrations. So we'll get there, but I think for now, just putting your ear close to them and try to see whether or not some of these movements provide any information. I've been successful in treating patients without diving into this. With that said, I do think it will be something that really ups our game. Mandibular range of motion, over bite and overjet. Let's go over there. So this is the diagram that I use. At least this is what I think of when I try to define what overjet and overbite are. Overjet is the horizontal component of the relationship between the upper and lower teeth. You measure that according to the facial surface of the lower incisor at the relation of where the upper incisor edge is. The overjet, they can't see. Yeah. The overbite is the vertical component at this level where you can fit the probe. Obviously, depending on how you fit this probe, you can get different measurements. We're just looking for very broad strokes. Obviously, we have iTero scans that help us get this information on the fly. With that said, this is how you find them. So going back to overbite, overjet, and midline. So that's midline discrepancy. So the difference between the two midlines. Maximum painless interincisal opening. So you have them open as wide as they can. And this is a tool that we use called the Therabite. You can use a regular ruler. At the end of the day, we're not looking for exact measurements, but the straight ruler is a little bit clunky, especially for certain patients that have malocclusions. So somebody invented this guy. And let's see if they have a tool or a picture showing the tool. No, I guess not, but I would go to their website and just look how they do. They have the lateral scale for lateral excursions, which we'll look at in a moment. And then this notch goes into, well, I guess they're using it here. No, that's for lateral excursions. All right, so here's the photo here. The little notch goes on the lower incisors, then you have them open as wide as they can, and this will measure their maximum painless opening. So you basically just have them stop when they start to feel discomfort. Then you have them go as much as they can in a painful manner. These two things help us to diagnose. Then you're going to have them go into right lateral. How far can they go? Again, this is protrusion. So essentially lateral would be, you have the patient bite down, you look at where the midlines are, then you take a look at their lower midline and make a reference point on the upper teeth. If they're coincident, then you use the midline. If they're off by a few millimeters, just make note of that. Then they go to the lateral and you measure where the lower midline is in relation to the upper midline in a horizontal component. So you're assessing how far to the side can they go. The average is somewhere between 10 and 13. Typically I see around 10 to 12. You're looking for, is it a 4 or 5? Or are they very lax in the joint and they can go even farther? Protrusive, have them go as far forward as they can. Obviously, is it painful? And then the pain location. So you want to just identify where the location of the pain is. Deviation on opening. So you're going to have them open wide. I actually started doing videos for this. It's helpful to, rather than try to describe it with words, have a video of it. At some point, we will incorporate this into our diagnostic data, similar to what we do when we have patients, say, 55, 66, so on and so forth. Deviation upon protrusion, so you're having the patient slide forward as far as they can, and is there a deviation, how far, and to what side. These are broad stroke measurements. You're not going to glean any information getting information from 2 millimeters to 3 millimeters, so on and so forth. The muscle assessment, this will take some time and some training, if anything, but I did have, let's see, a little video here. Why don't I just play it?
You're going to be sitting to the right-hand side of your client, and you're working on the masseter muscle on the right-hand side, so that's the position I'm in here. The masseter muscle inserts into the side of the mandible here, and originates from the zygomatic arch. So your access point is going to be the region between the lips. You're not in the mouth proper, you're not between the teeth, you're just actually in the cheek. And as you proceed posteriorly, then you're going to run into this muscular border here of the masseter coming down like this. If you're not sure that you're on it, you get the person to clench their jaw and the muscle will perk up and into your finger here. So you need to explore the masseter all the way from the inferior part of it all the way upwards. And I like to come into contact with the border of the muscle with my inside hand, and then my outside thumb rolls the muscle onto my inside finger. And in doing it in this way, I can scan the entire muscle for myofascial tension.
What is myofascial tension? That's something we're going to develop over time. Most of what we're looking for are trigger points. As we all know, Ashley, our assistant, had a series of unfortunate treatment done on number 3. She had fillings, a crown, endo retreat, ultimate extraction, and then when she joined the practice, she had no tooth there. I went in, did something similar. I massaged, did a myofascial release. I felt the trigger point right about here, and for about a year after, she had 0 pain. So she went from 10 to 12 years of a painful tooth to not having any pain. She felt the pain here. Trigger points have referral patterns, very predictable referral patterns. And if you haven't looked at the trigger point PDF that we have in the shared drive, I'd encourage everybody to look at it, print it out, and have it on their desk. It's a very common presentation that patients think they have a toothache, but it's actually a muscle pain. So what I would say is, when you're feeling in here, now the person doing this video is probably assuming the audience knows what myofascial tension feels like. Let's talk more about tight muscle bands. You will feel almost like a rope going like this. So the muscle bands go vertically, very parallel to the ramus. Again, they insert in the inferior border of the zygomatic process. You will feel a rope literally going from here down. If you feel that rope, you pinch it and let it release. That's not the solution. That's just another tool. But sometimes it gives patients the confidence that you know what you're doing. So we need to know how to feel for those. And several of you, I've tried to bring patients with this tension to your hands so that you can feel it. All right, so that's the masseter.
In order to access the temporalis, we need to understand the temporalis attaches all along this region in the skull. It reaches underneath the zygomatic arch to insert into the coronoid process here. An interesting anatomical fact is that the anterior fibers of the temporalis attach along the anterior part of the coronoid. And as you proceed more posteriorly with these muscular fibers, the tendon attaches more and more posteriorly along the coronoid, until the most posterior fibers attach along the back margin of the coronoid. So to contact the muscular insertion of the temporalis, you need to reach into the mouth again, and once again, you can just be in the cheek. You should feel the back of your finger along the lower margin of teeth as you proceed posteriorly. And then you'll run into this plate of bone, which is the mandible, and you run up along the inside with your finger pad. And you get to about this point, and you're going to run into the first insertional tendon of the temporalis. So if it's swollen or sensitive or hard or firm, you're going to usually find hypertonic fibers in the temporalis in the same region. Very often, you might just treat just the first few millimeters in here at the coronoid, and then the first few muscle fibers of the temporalis the first time out. But as things progress, then you're going to be progressing along the inside of the coronoid process. You may run into some obstacles here, so at a certain point, it's helpful to ask the client to open their jaw a little bit, and then you can sink in higher on the coronoid process.
I would encourage everybody to feel their temporalis muscles regularly. You'll start to feel what myofascial tension is. At least for me, if I'm more stressed, I tend to feel that more on myself, and it's good because you can feel it bilaterally and you get a much better sense of the tactile response because it's your own body. So don't be afraid to practice on yourself. Great way to learn. Before I start with the lateral pterygoid, there's quite a bit of argument whether you can actually feel it or not. Spear talks about doing an indirect assessment of the lateral pterygoid, but let's see what this guy has to say.
The muscle I'd like to explore is the lateral pterygoid muscle. It attaches in this blue region on the front of the neck of the condyle of the mandible, and it comes from the lateral pterygoid plate, which is inside the skull here. It's the pterygoid. It's the lateral pterygoid plate here. So the muscle actually runs in where my finger is, although it attaches on the inside here. Let's just take the jaw off for a second. So you see along these teeth immediately, and then you'll run into sort of a firm gum-like tissue, and that will be the belly of the muscle. Sometimes you can come in underneath, you can contact the muscle this way. To access this muscle, I like to stand up and walk around, and then I open the jaw, and I slide my finger along the upper set of teeth, and then I proceed more immediately until I run into the pterygoid, the lateral pterygoid plate with my forefinger here. So I'll scrum it or contact it. As the muscle relaxes, sometimes I'll just shift the jaw a little bit posteriorly in this direction to stretch the attachment in there. That's the lateral pterygoid muscle.
Again, that's very controversial, whether it can be done or not. If you're getting it, you're only getting the anterior/medial component of it. So are you able to palpate the entire muscle belly? No, it's extremely deep in there. It's sitting right, it attaches to the condyle, which we can't get access to. With that said, there are other methods, and we'll go through that as time goes on indirect ways to assess the lateral pterygoid.
The medial pterygoid muscle comes off the medial pterygoid plate of the sphenoid and inserts onto the inside corner of the angle of the mandible here. So some people will access the muscle from reaching in this way. If you need to access it internally or intraorally, and this is the gaggy, the potentially gaggy muscle. So you need to open the jaw, have the person open the jaw, and then you reach in between the upper and lower teeth. And you have to be on the inside of things here. You run into the pterygomandibular wraith, and you go a little bit more posterior to that, and then you run into this muscular wall of the medial pterygoid. When you get to that muscular wall, gentle pressure that's directed towards the external auditory meatus tends to isolate your force, so it's at right angles to the muscle. A gentle contact there, some patience, both therapist and client breathing, and then that muscle will often relax nicely.
As you can see, he's providing myofascial release, which may or may not come from something called ischemic compression. So when you provide ischemia by applying pressure to a muscle, you then starve the nerve, and the nerve has to release. So a lot of times these muscles are under constant neuromuscular firing. That's when essentially a muscle is in spasm. To release it, one way to do it is to starve the nerve of blood supply. There's much more to that with specific myofascial releases, so on and so forth, but simple pressure and just relaxing tends to provide some relief for the patients. So there's more muscles here, the SCM, so on and so forth. I tend to focus on the ones that he just did. With that said, as we get better, we're definitely going to get into the head and neck muscles more. There's a lot of information we can glean from that. Fibromyalgia assessment, I don't do any of this. This was just on this form. If anybody wants to dive into that and see how we can bring this into our analysis, we can. This document comes from the Oral Facial Pain Clinic at the University of Florida. They're seeing patients with a whole host of issues. We're obviously not getting referred patients that have fibromyalgia. So do with it as you may. Dentition, I don't really do any of this. We already have this information. Eventually I'll create a nice clean document without some of this unnecessary information. Same with this. I might comment a little bit on the salivary gland flow. Why is that important? Well, if there's abnormal flow, there might be something impinging on the parotid, which may also be affecting the joint. It's not the joint that's the problem, it's something else that's the problem. So this isn't a helpful bit of information. Occlusal assessment, quick enough to put in there. Occlusal function, so are they, when they go right and left, are they guided by their canine only? Group function, are they guided by their canine, their premolars? Partial group function, I guess that would be just one premolar. Balance function, I don't know anybody who has balance function. That's a denture setup to stabilize a denture. Balancing would essentially be you're grinding to the right side and your left teeth are touching at the same rate as the right side. I've never met anybody with that. If anything, they have balancing interferences or non-working interferences that lead to the problems, but never a specific occlusal scheme that is stable and functional in that regards. So here's your lateral interferences. Your working interferences is the side that you're going towards. And then the balancing interferences are the opposing sides, also known as non-working interferences. Protrusive guidance, when they slide forward, are they on the anterior teeth or are they on their posterior teeth? We don't want this. Dawson spent a greater part of his career preventing posterior teeth from touching during lateral and protrusive function. And that was 90% of his whole shtick, was TMD is caused by interferences outside of normal protrusive and lateral excursive movements. Crossbite, are there any teeth in crossbites? Occlusal vertical dimension, just a general sense here. Where facets, where are they? I tend not to get too specific here. With that said, I don't think it hurts. We have so much data when we take our photos, diagnostic photos, and our iTero scan, that I can look at this stuff. The guy who came up with this technology, or this form, did not have the technology that we have today. Fremitus, holding your finger across the anterior front 6 teeth and have them tap, 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 and then do the same in the posterior segments. Do you feel any movement when they tap? That's fremitus. Centric relation and initial contact. This is by use of a leaf gauge. Essentially, the use of a leaf gauge is you find the number of leaves that allow the patient to go into MIP, and then you have them slowly bite down with that leaf gauge in between their front teeth, and where's the first point of contact? That's centric relation. I'm not sure whether or not I believe that centric relation is as powerful of a concept as we were taught in school. I'm much more inclined to think the muscles are really what tell us where things need to be. With that said, if you want to find centric relation, there you go. Centric relation intercuspal position slide, CRCO slide. I just don't think it's relevant, to be honest. If anybody wants to get some help in learning what this is, it's irrelevant if we're going to use the muscles to tell us where to go. And that's kind of where my journey has led me in occlusal philosophies. Oral parafunction, pretty self-explanatory. Past dental history, imaging, so on and so forth. Diagnostic anesthesia. This is cool. We can isolate certain trigger points. We can inject extraorally to try to rule out intracapsular versus extracapsular issues. Topic for another day, and then others, just any other information you might find helpful. Diagnoses, recommendations, those we can do together. This is not, if you guys are going to do this, and I encourage you to do this, let's have a whole separate conversation on this stuff. I mean, that's a lot of what SPEAR, the entire continuum, teaches you, so it's not something we can do in a video. But I just wanted everybody to know that there are a whole set of diagnoses in the medical realm. So these are not CDT codes, they're not dental codes, they're medical codes. We'll go over all of this once we dive into the specific data. All right, so leave these empty. We will do these together. But if you can get all of this stuff from your patient, you're going to be doing them a lot of help. It's very helpful for us to provide an aqualizer for these patients as a diagnostic tool. Tell patients this is a temporary attempt at treatment, but more importantly, it's a diagnostic tool. For example, some patients get worse with the aqualizer. That helps with the diagnosis. We'll dive into what that is. All right. That is the TMD diagnostic workup for our practice. I hope this helps. I hope this encourages more of you guys to start diving into this. We will spend a lot of our CE efforts learning how to use this data appropriately. Most importantly, how it dovetails with sleep. A whole nother realm of this is the sleep analysis and getting all of that information that's necessary to come up with a good diagnosis. All right. I look forward to helping you guys with this part of your journey. Take care.